Hi, I'm Dr. Frank Dumont. I'm the Commercial Medical Director here at Virta Health, and I'll be kicking off our third session here at the conference, and we're going to be focusing on the rising healthcare costs, the prescription costs, and the cost crisis associated with prescriptions. So why this topic? Well, what we know is that patients are struggling with this, as are payer systems. The medication costs are going up. People are actually struggling to be able to pay for these. Some patients are going into debt in order to be able to afford their medications, or they're prioritizing other costs. Some people are actually rationing out medications which have been prescribed for chronic conditions like diabetes and other chronic diseases. So this is a problem, and it's part of why we've chosen this topic. What we know is that this is a rising problem. It's an ever-growing problem. There's no end in sight, and so this is a challenge for both patients and for payers. Now, this is at the heart of what we do here at Virta, where we're reversing type 2 diabetes. I spent 20 years as a PCP starting medicines to try to control diabetes. I now spend most of my time trying to stop medicines and being able to stop medicines with patients as we address the root of the metabolic problem. Now, we're going to, before we get to the larger panel to discuss this a little bit further, we have a special guest with us here today, Kevin Swire, who's been a patient here with us here at Virta for the last 4 years. And he's going to tell us a little bit more about his personal journey with regard to diabetes and his diabetes reversal process. So again, I want to thank Kevin for taking the time to speak with us today. Welcome, Kevin. How are you doing today?
Oh, I'm very good. Thank you.
All right, great. Well, let me start out with just a question about your journey. Tell us a little bit about your story, about how you were diagnosed with diabetes and when, and how did it impact your life?
So I've been a diabetic for a little over 10 years now, and it was an absolute shock to my system. Diabetes was something that happened to other people. Nobody prepared me for it. I didn't have a family history in it, but the choices that I were making were definitely what led me to them. And I always questioned, why was everybody willing to do so much after my diagnosis and not before it, when they all saw this coming? I actually went to a doctor for 6 months and trying to figure out why I had to go to the bathroom and urinate as frequently as I did. And nobody bothered to check my blood sugar for 6 monthly visits that I was making. And finally they did, and I had a blood glucose level of 300. And they said, "Oh, it looks like you might be diabetic." I'm like, and it was just shocking to me. And then I had to just reprogram my life. And since I wasn't very well educated or well versed on what diabetes was or how to live with it, I relied on everything my doctor told me. And the doctor rolled out a series of medicines and then added insulin and gave me some instructions on how to just make changes to my insulin levels and just keep taking my medicine and keep buying it every month. And that's going to be life for you.
Right. Yeah. And of course, that was my experience in 20 years as a PCP. We were taught to prescribe more and more medications trying to control diabetes. That's really been the standard of care. So can you tell us a little bit about how that was for you in terms of taking all those medicines, whether there were challenges with that, either in terms of the medicines themselves or the costs of the medicine? And then, maybe tell us how that wasn't serving you as well as you had hoped. And also then maybe if you can bridge into what things look like for you now that you've worked on reversing your diabetes with Virta.
So the medicines, some of them worked, some of them worked sometimes, some of them worked not so well. And it was a constant juggling act. The most insidious of all of them, I think, was the insulin regimen that I had been put on, because I kept being told these ways how I should increase my insulin based on my readings, but nobody ever talked about anything about being down. And sometimes the insulin worked and sometimes it didn't. I equated to being on a roller coaster ride. It was like buckle up, because on a day-to-day basis, you didn't know where insulin was going to take you. Now, some of the other medicines are a little bit more benign, and I'm still on a few to this day, like metformin. And I envision being that on my life. But the most important part that I added to it was when I added the Virta And Virta gave me an opportunity that after 7 days on Virta, I was able to leave insulin behind for good. And I don't envision ever going back to it in my life, because I know what the challenges of being on insulin were, and I don't ever want to experience that again.
And when you say the challenges of insulin, are you referring more to the logistics of having to do injections on a daily basis, or more the safety, or more the cost, or a combination?
Frank, it was everything. I mean, just there wasn't an aspect on it, like on the days where it worked fine and my blood sugar came under control, that was fantastic. But for every one of those, I had 3 where I would either bottom out, and I'm considering taking some kind of sugar additive to like get myself back to feeling right, or sometimes it just wouldn't work and I'd have to increase my dosage, and then you'd keep that dosage for the next day, and all of a sudden you'd be bottoming out again. So you had no idea on a day-to-day basis, and we kept adding in more and more medicines. Metformin led to glipizides, led to Trulicity, led to insulin, led to all these other things and stuff. And I've been able to leave the majority of them behind, just because I learned something about how my body works and how my body interacts with diabetes, and how I can make changes that don't involve insulin, that not only here I am 10 years later and I feel better than I did 10 years ago. Without even trying, I lost 80 pounds, and it just came like I just couldn't understand where all this weight was going. I really wasn't changing that much. I had changed the kinds of foods that I was eating, but Virta gave me these plans that allowed me to substitute foods that I liked with more carb-friendly foods that were better for me. As a result, I've been sleeping better. I have been feeling better. I have become more active, and I feel better now at my age than I did 10 years ago.
Wow, that is amazing progress. And it's exciting to hear how things have really changed in terms of your health and your quality of life. So not just then coming off of medications, but a number of other benefits. Going back to the medicines for a second, did you ever struggle with the cost of your medications? You mentioned insulin, which we know has been a problem in terms of the skyrocketing costs of insulins, but you also mentioned some other trade name medications. Was cost an issue for you, and has that changed significantly?
Well, I am so, happy, whenever I hear these things about the cost of insulin being debated almost as a political issue, that it doesn't affect me anymore, and it's never going to again, because I found an alternative that's so much better. Metformin is a very, very inexpensive medicine, and I still have it as part of my routine. However, Trulicity was extremely expensive. I felt it kind of worked, but it wasn't giving me the benefits that I'm seeing now. So I'm happy to leave all of that behind. And, the last time I got interviewed on this, I kind of put a pen to paper, probably saving me, just shy of or just over $5,000 a year in terms of medicine costs, in terms of what I was doing. And that's not even accounting for all the recent things that have been going on with the costs of insulin, and being bandied about as like I said, as a political topic. And so I'm just so happy to be free of that. And, my family is very, very proud of me, and no more so than I'm proud of myself, because of all the opportunities that I now have, to live a better life. And, we make subtle changes around family dinners and things like that, but I feel so well supported by not only my own family, but by my Virta family, that kind of is always there for me, always pointing me in the right direction, and making sure that I can stay true to my commitment to keeping this as the rest of my life is the way that I handle with I deal with my diabetes.
Well, I can understand why your family's proud of you, and you should be proud of all the changes that you've made. Just to clarify, you mentioned over $5,000 in cost. Was that your personal cost? Was that co-pays and deductibles?
Yeah, no, it was because there were some things that, you had to lay out of. That was what was coming out from a monthly basis that I have now abandoned. Now I still pay for metformin, like $10 or whatever it is a month, whatever. But the majority of these things were the other medicines that I referred to. And, as the insulin went up, the cost went up. You had to buy more just to get yourself through the month, and going and getting prescription renewals, and Lord knows all the different things that were involved with it. But we kind of jotted it out and we said, oh my God, look at the impact that this is making. And it's a better alternative. And I feel better about myself. I'm making better choices. I'm helping other people. And that's the number one thing, believe me, because I really feel like Virta saved my life. And I wouldn't have the quality of life that I do now without Virta. So any chance I get to help anyone come into the light that I found is a chance that I just want to take advantage of.
Well, I want to talk about just the way that you've helped to share the message and any other thoughts that you have for other people who might be struggling with diabetes. But before we do, I did want to touch on the nutrition, because one of the things that I've heard as a concern is that eating healthier can be really expensive. Have you found that to be a challenge for you or a problem? Do you feel like that's been balanced or counterbalanced by being able to stop medications? Are you struggling with the cost of foods now?
Well, I think everybody's struggling a little bit with the cost of foods now, and that doesn't have anything to do with the current, diet that I find myself, adhering to. I eat good foods. I don't feel challenged at all. I don't eat. There's some things that we do, like heavy cream instead of milk, and it's wonderful. It's a great choice. The only problem is that heavy cream is in a little bit of a shortage right now. So yeah, I mean, there are some issues, but it is more than offset by what I'm saving and what I'm feeling so much better. Having the confidence to manage your own health and manage your own situation to the extent I'm now able to, it's priceless. So, when you talk about these costs and things or anything else, I don't even bother to pay attention, because I'd pay 10 times this to get to be where I'm at right now, because it's just so much better.
All right. Well, so are there any other messages or ideas that you would want to communicate to people that might be struggling with type 2 diabetes, either with managing it or with regard to the costs?
Yeah, and I'm going to tell everybody the same thing. I wish someone would have grabbed me and shook me 10 years ago and told me, he goes, avoid this if you can, learn about it, but learn about it not just by listening to your doctor. Do your own, investigate what Virta offers. There are people I know that are 30 years old that look like they're Olympic swimmers that are leading a keto-friendly lifestyle, which is kind of the backbone of what Virta is. It gives you so much positive into your life that I can't stress it enough. As a result of this, I have a sedentary job. I pretty much sit at my desk all day and do my work or whatever and stuff. But I've taken a second job as a football referee, and I'm running up and down the field. And Lord knows, it wasn't 2 weeks ago when somebody broke a 35-yard touchdown. And here I am going, because you're not supposed to signal touchdown until you're at the goal line. So I got to get there as quick as I can. And I'm literally like maybe around the 10, 15-yard line saying to myself, if it wasn't for Virta, I wouldn't be here doing this, having as much fun as I am. So I can't stress enough to everybody that they really ought to become educated, find out what it is that's going to work for them, and realize that there isn't just one way to go after it. There are many ways, and try this one on. It may work for you, because it did for me. And if I can help anybody get to where I'm at, I'll feel like I did my good deed for the day.
All right. Well, Well, thank you, Kevin, again, so much for sharing your story. You continue to inspire me and us at Virta and thousands of people around the world that have heard your story now. So thanks again for taking the time today. Now, up next, I'd like to give a warm welcome to our panelists that will be coming in to discuss this in more detail. First, we'll start with Dr. Chantell, who is the National Pharmacy Lead at Willis Towers Watson. She has over 20 years of experience in the managed care pharmacy space. She'll be joined by Dr. William Shrank, who is the Senior Advisor at Humana. He's also served recently as Humana's Chief Medical and Corporate Affairs Officer. They will be joined by Sharon, Jhawar, who is the Chief Pharmacy Officer at Scan Health Plan. Now, she's been a key organizational voice, and she's been influencing Medicare policy for more than 18 years. And then finally, Ron Harrison will also be joining. He's Vice President of the Business Development at the Mark Cuban CostPlus Drug Company. He's been in the business of pharmacy for his over 30-year career, and he's previously held leadership positions at Anthem Blue Cross Blue Shield. So a very warm welcome to the special guests, and I will kick it over to you, Chantell, to start the panel. Thank you.
Thank you so much, Frank, and really a great preview to our session today. Thanks for teeing the importance of the RX cost crisis up for us. And it was really inspiring to hear Kevin's story as well. So we thank him for that. And really, again, thrilled to be here to moderate this session. I think we have a fantastic panel here for you today. We represent a lot of different areas within the healthcare ecosystem, and all of us are tasked each and every day with trying to get lower cost medication to our patients and our members. And I think I'd like to just start the conversation with just a general question about any misconceptions about the pharmacy cost crisis that we think can be addressed, just to help us level set and understand what the core issues are. And I think we got a little bit of that before, but maybe, Will, can I start with you just to kick us off here?
Sure. Thanks, Chantell, and it's great to be with you all here today. I will just build off what Kevin had to say. We often talk about the prescription drug cost concerns or crisis from a societal perspective. We talk about how, we can't afford to continue as a country or as a health system to continue to just assume responsibility for the rapidly rising cost of prescription drugs from a policy perspective, from a budgetary perspective. But this is personal. The ability to afford your medications, the ability to manage chronic conditions is hard, and it's complex. There's a whole host of lifestyle issues as well as medication issues that every patient has to manage for themselves. And even with good insurance, the cost of these medications can be really, really burdensome. And the assumption that if you have insurance and that you can just you can easily access any medication that's available out there is very, very far from the truth. And if you look at the evidence around how people adhere to their medications that are prescribed for essential medications for important chronic conditions, it's really disappointing and depressing, frankly. And this is these issues that Kevin, I think, really brought to life around the very personal nature of the cost of prescription drugs, even for those who have insurance, is really important to keep top of mind.
I'm glad you brought that up. It is that I saw that recent study that just showed the unaffordability of prescriptions for people with insurance, and it is devastating, honestly. We know in all of our top drug lists, we have all the chronic conditions, diabetes, as Kevin and Frank mentioned. We have autoimmune, we have HIV, cancer. We even have weight loss drugs now, which I'll get to a little bit later. And just in generally, we're seeing that healthcare costs are going to rise about 6.5% next year. We know some of that was deflected just due to the pandemic and COVID. But maybe, Ron, I'll put this one to you. How do you think employers and health plan leaders should prepare for this and mitigate the rise in the cost that we know is going to happen?
Yeah, thank you. I actually also wanted to just address the previous question about misconceptions, because one of the things that we're really trying to battle and ensure that people understand is that the pharmaceutical manufacturers are not necessarily the evil doer in the rise of prescription drug costs. That prescription drug costs are rising because of multiple entities within the supply chain, whether it be to some extent on the pharmaceutical manufacturer side, but there's also responsibility on the wholesaling side, as well as the pharmacy benefit manager and the pharmacies in some cases. And so what we're really trying to tackle is the cost component of the rising cost of healthcare. But it is also really great to hear from the gentleman that spoke earlier, Kevin, around changing his diet and trying to find more healthier foods, which is difficult for some people in some parts of this country. I think in terms of being able to prepare, one of the things is to have preventative type of prescription drug programs for the members, as well as putting in other wellness programs that they can employ. But those are all very costly, and health plans and employer groups don't necessarily look at the immediate return that they have on some of those programs, and they're not necessarily looking further down the line like they should be, right? So the easiest thing for them to do potentially is put in preventative RX types of programs, reduce the cost of the prescription drugs, especially the gentleman mentioned metformin. Metformin is a drug that should be less than $10 for a consumer. But unfortunately, due again to some of those supply chain issues, the cost of the drug is unaffordable to individuals. But it's really around preventative care, providing wellness programs, providing good consumer information to help reduce the cost that will come eventually down the road.
Yeah, you make really great points there, and I think important just to understand that even some of the generics are not affordable, which is where we're at here. So we heard a little bit from them too around insulin and the regulatory efforts there. So I think that is certainly interesting. But what are financial and health benefits of focusing on reducing or even eliminating the medications instead of making them cheaper? So maybe I will kick this to you, Sharon, and how do you think this can be done?
Yeah, so a couple of things. Thanks, Chantell. Obviously, right, making medications affordable is key. Just to give folks a little bit of background, I'm with an organization called Scan Health Plan. We're a Medicare Advantage plan. So as you hear me speak, it'll be more from the Medicare Advantage serving older adults perspective. And one of the things to Ron's point about there's so many folks involved in the supply chain. On the insurance side, our heavy emphasis is on ensuring we negotiate every step of the pharmacy supply chain to make sure we can offer our members the lowest copay benefits. And so through our efforts and our rigorous kind of negotiations all the time, and you have to be willing to make tough choices, whether that's, certain pharmacies in the network, out of the network, certain manufacturer coverage, others, or changing your PBM, whatever that may be. At the end of the day, those are those tough decisions that help you provide older adults with affordable medications. And so that's one key thing that we do to ensure that we are able to provide an affordable benefit and supplement over the, quote unquote, standard Medicare Part D benefit. So with in Medicare Advantage, we are able to, do things that are a little bit different, where you have day one coverage of your medication. For generics like the metformin that we were talking about that Kevin was on, we provide that for $0. Insulin in our diabetes products, we're able to provide that for $0 as well. So what we find is that there are ways in Medicare Advantage to make medications affordable, things like the costly GLPs, being able to cover them for about $30 a month. But what we find is that right, our healthcare system still is tilted towards always prescribing, as opposed to really getting to the root cause of food as medicine. And so some of the additional types of programs through designing in the Medicare world, it's value insurance-based design, VBID, that we partake in. It allows us the ability to have nutrition types of programs whereby, you don't have to worry about just 1 year and your return on investment of helping someone focus on changing their health and behavior in order to get better health outcomes. So those are some of the ways that we are focusing on incorporating behavioral lifestyle changes, nutrition, in order to help older adults really kind of take their health care from just being medicine, but actually, modifying what they're doing on a daily basis to make care more affordable. And to Kevin's point, he's healthier and he's happier. And so that's kind of the approach we're taking on the Medicare side.
That's excellent. And you make really great points. I think just this idea of other options besides medication and leveraging nutrition. I think we heard from the White House a couple of weeks ago on their initiative to really make better nutrition available, as well as just incorporating that. They had a very nice program that was focused on that. And I think this whole idea of helping patients be able to manage on a root cause basis this role of food as medicine really can help to mitigate some of the costs that we're seeing here. So I'd like just to open it up to the group in general just to talk about that and how broad we think that can reach.
I can share. So, from a SCAN standpoint, in terms of providing meals for older adults, last year we provided about 500,000 meals to our members. Now, when we take a look at how best to, because we can't do it, for everyone, we really hone in on our most vulnerable members at times where they need those meals the most. So sometimes, that means right after a hospital discharge, could they benefit from meals made for them, delivered to them? Or when their chronic condition, they have an exacerbation, whether it's diabetes or high blood pressure, and being able to provide medically tailored meals to them. Those are the areas where today we're able to help our members. We would love to figure out ways to, provide endless supply of meals for all of our members. That's kind of where we're focused right now. And then really our next step in our journey is also around culturally tailored meals and how to get better at that. Because, we can do medically low salt diets, we can do low sugar diets, right? But how do you do that for an Indian person? How do you do that, for a Chinese older adult? And so we're really focused on how to be able to do that better.
And you bring up a really great point of just being able to provide that access to the most needy at that time. And I think, just this whole idea of leveraging that for social determinants is really important here. And I'd like just to ask the group about that and just the challenges of impacting overall patient care, chronic disease management with weight management and obesity, just using food as medicine solutions like Averta, like the meal delivery service that you mentioned. How can that help, your overall populations?
It's really interesting. I think Sharon was getting at this notion of addressing food insecurity and patients with complex lifestyles. It's hard for them to access healthy food, and the ways in which SCAN is stepping in to try to be a partner and to try to help their members. And you're seeing this pretty broadly across the Medicare Advantage space and in Medicaid as well, the government-sponsored health insurance space. And I'm not sure anyone would have thought of it this way, that we want health insurance companies to be a big part of the answer around addressing underuse of social services or under availability of social services. We have we've gotten ourselves in a weird spot in this country where we're wildly over-indexed on healthcare spending. We're really good at paying for prescription drugs, and we're really good at paying for operations, and we're not really good at paying for social services. And having the opportunity through government health insurance programs where the insurance company is taking the risk, the insurance company has the ability to reallocate. It's also very hard in our political environment to reallocate dollars from healthcare to social services. but health plans can do it. And if health plans can make a fiscal argument that at least it's cost neutral, and by reallocating healthcare dollars to social services, to addressing some of these upstream causes, drivers of bad health, if it doesn't adversely affect the bottom line, there's every reason to do it. So there is more and more momentum here. You're seeing, like in the Medicare Advantage space, the majority of plans are offering very rich benefits around food. But I don't think we've gotten to the place that, Sharon, you were sort of getting at, and I think, Chantell, what you're asking about. How do we make sure that we're using those benefits right? How do we make sure that those dollars that are being allocated to go to the local grocery store to get food is being used to get the right food? And how do we make sure that, it's the right food for the right patient with the right condition? And we're starting to fill in some of the holes, but there is also exposing so many more holes in terms of the challenges that patients have, that people have in the real world, figuring out how to manage their chronic conditions. And I think this is the right conversation for us to be having. How do we take these benefit opportunities, not just, how do we move that to something that we can really demonstrably show improves health?
Just from a personal note, I go to the gym and I'm running on the treadmill, and across the street from me is a national burger chain. You can feed a family of 4 for less than $20. A hamburger, Coke, and fries for everyone. And there's, on the way home from that gym, there's probably 3 or 4 more burger places that I can stop and feed a family of 4 for $20. But if I want to go get a salad or something really nice, you got to go out of your way and find it. And I live in a community that has that access. And so, how could employers, insurance companies assist people in finding healthier foods at an affordable price is something that I don't think really is being addressed. And so it's nice to hear, Sharon, what you're doing for older Americans that maybe can't get out of their house and don't have that ability and can have that delivered to them in a culturally sensitive need in a way is really inspiring. But it's the reality is burgers down on every corner.
And I think that Will, you hit it on the head. The challenge is right. How do you be able to be there for everyone the way they need you, and how they need you, as well as at scale. So SCAN, we actually started out back in the 70s, where in Long Beach, California, where it was a group of 12 angry seniors who really wanted social care and their medical care coordinated together. And they formed Senior Care Action Network. And so, our DNA is a little bit different in how we evolved into a Medicare Advantage plan. But that notion of, improving, I would say, the healthcare delivery system, because it is so fragmented, to really understand, hey, who needs our help with food, who needs our help with housing, who needs our help with transportation to get to medical appointments. I think as a healthcare system, there is so much to improve upon in order to improve the health of Americans.
So follow-up question here from our Q&A. Did you see better outcomes and cost savings when you provided the meals?
I don't know if we've studied it to the nth degree to know the health outcomes to share numbers with you. I know that when we think about our members at that particular time where they need that help, we know that it helps. We know that at the root of it, if we're helping, exacerbated diabetes, for example, right? We can make their metformin, 0. We can make their insulin 0. But if the food isn't right, they're still going to end up in the hospital. And so by providing them those meals, are we getting them on a better track for the amount of time that we're able to provide it, like the 30 days? And hopefully then, through programs like VERTA and others, it invokes the behavioral change like Kevin talked about. He's never going to go back and eat unhealthy again, right? Once you get on the right track to sustain it. I don't have proof in terms of numbers and stuff, but do we make changes in people's lives as a result of getting them on better food? I would say so, totally.
Well, let me just to build quickly on that. Agree completely, Sharon, with how you frame that. along with some colleagues of mine at Humana and colleagues at Rand and at UCLA, we published a systematic review of the literature of interventions funded by payers to address food insecurity or hunger and their impact on food insecurity, their impact on health outcomes, and their impact on costs. And what Sharon highlighted is exactly right. First of all, there's very, very clear evidence that you can address food insecurity with these programs and that those impacts can be durable. But it is hard to organize a study in a way that's like that you can demonstrate, because some of the outcomes you're trying to avert can be meaningfully downstream. It's very, very hard to, and you'd have to do a really large study because those outcomes are somewhat rare. It's very hard to show reductions in total cost of care or meaningful reductions in downstream hospitalizations. However, these programs to date that have evaluated generally don't show that they cost anything. They're generally cost neutral. And I think that should be really refreshing and reaffirming. If you can feed people and it doesn't cost money, that sounds like a pretty, if it doesn't cost money from a payer's perspective, that sounds like a pretty good deal. I think one of the things that's challenging is in the payer space. And I think, SCAN is a very progressive plan, so maybe you think about it a little differently. But in general, most plans are looking for, well, what's the financial return on the investment we make for this population? However, if you can make an investment that makes their lives better and is cost neutral for the plan, all plans are going to do that all day. And I think that's sort of a framing that we need to adopt. Can we at least demonstrate it's cost neutral and improving the lives of people? And if so, it's time to scale it.
So I'm going to just change gears slightly, but I think the thought, we heard Kevin say that his doctor just prescribed the insulin and told him how to take the medicine and added more on. And do we think we'll get to a place where we have like food as medicine as a standard, where we have practitioners that are using it as a root cause to help treat symptoms overall? Or do we think it's going to take some time to get there?
Well,
So
I'll tell you.
Go ahead.
I'll tell you go ahead, Sharon. I'm sorry.
no, you go ahead.
So I'm not sure the answer is to require it for everyone as a first line. But it certainly should be an opportunity for everyone. I think those are two different things. One is to say there's only one right way to manage any given patient. And it's always going to be preferable to address a complex chronic condition with behavior and eliminate the need for in perpetuity expensive medications that are going to potentially have side effects or downstream consequences. But I think we also have to be somewhat realistic around the fact that behavior change is hard. And, if it was really easy to look as healthy as Chantell, Ron, and Sharon, everyone would do it. But it's hard. And, we 40%, the numbers are enormous, the percentage of Americans that are obese. And behavior change is really hard. So I think you can't be that prescriptive today until we learn a little bit more around who uses, who engages, who persists, who maintains the weight loss and the diet over longer periods of time. Make sure essentially we're not contributing to disparities in care by saying there's only one recipe for everyone. And, it might be that some certain subpopulations have a harder time adhering to the diet or adhering to the different lifestyle changes. So I think we have to maintain flexibility, but I think we'd be really, really, really short-sighted not to offer a food as medicine option for everyone who has the opportunity to leverage lifestyle changes to make meaningful improvements in their health and their healthcare trajectories.
No, I think the dialogue around explaining that the importance of food. I just think about my own personal life, right, with my daughter. The one tidbit I have taught her is right now it's all like hot dogs and chicken nuggets for her, right? I just taught her high fructose corn syrup. If it's in there, it's like poison in what you eat. And that one simple thing, now when she says, oh, Mom, I want this lemonade, she goes, oh, it has high fructose corn syrup. Okay, no. And that one small thing, right, might make a difference as she ages. And so how do we just think about, really paying attention to the food that we're putting in our body? I fully realize that, everyone has challenges in what they can afford and whatnot, and everyone's situation is different. But that extra emphasis on how we modify what we put in our body, I think that's powerful. And whether it doesn't necessarily have to be the physician all the time having that, message. But how do we create an ecosystem where we're all talking about it? The pharmacist, the physician, the social worker, everyone, and putting it out there, like Will says, as a conversation and the option.
It's a group effort. It really is. And I think, Will, you brought up obesity just as a point that you made earlier. And I think we are at a tipping point here. I think we personally in the Pharmacy Collaborative at WTW, we've seen GLPs rise to the top 20, to the top 10 for some clients, to the number one drug for one particular employer. So I would love to hear from the group how you think the pipeline of, it could be diabetes drugs, it could be obesity drugs, just being able to use a drug and it maybe even in place of diet lifestyle interventions is going to impact overall RX costs and just the trajectory in general.
Sorry, it's not sustainable, right? We can't continue to have the escalating drug costs that we have and the thought that we can treat all these ailments with medications, right? We do have to have some other mechanism to help control people's weight and whatever it is. There's obviously some conditions that clearly have no other choice but taking a medication, but it's definitely not sustainable. I think that we need to have more prior authorizations in place that are thoughtful and technical and are done by third-party entities away from the entities that are generating the revenue from dispensing these medications, so that the right person is receiving that medication and that they're receiving the right treatment first before they receive a medication. And I think that's one of the biggest problems.
So can I just build on that a little bit, Ron? So if you do have mechanisms in place like utilization management, prior authorization, we even see high rates of approvals for those medications anyway, because it's quite easy based on the FDA labeling of a BMI over 30. So does the group have any, do you or the group have any creative ways to, either modify that PA criteria, leverage vendors like Virta or other weight loss programs, either in advance of receiving a GLP or other weight loss medication? I'm just trying to think outside the box.
Yeah, I'll just pile onto it. And, I'm not a clinician like the others on the phone here, but I'm a little bit familiar with prior authorization protocols and step therapy, and none of them that I can think of have anything to do with diet and exercise before you get your medication. That's not a step, right? The step is what other medication have you tried first? Maybe part of the step therapy protocols and prior authorization process needs to include something like a Virta or some other program that you have to be involved in before you go directly to a medication, or be used in tandem with that other program. But again, as long as the financial incentives are misaligned for those that are providing the prior authorization, it's not going to change, right? So just because it is in the PA protocol or in the package insert that this is the acceptable regimen for that particular individual doesn't mean that everybody needs to have that particular drug, and that's, I think, part of the problem.
Yeah, you make a really great point, and I think we've actually explored that as a potential to step on a weight management program like a Virta before entertaining the GLPs. So I think there's appetite there, and I think employers are struggling a little bit because the drugs can be very effective and they work, and we're in the pipeline. We know there are other drugs that are even more effective or equally effective, rivaling bariatric surgery, for example, that will be coming next year. And I think I even saw additional drugs in early stage pipeline that are on track to be blockbusters as well. So we see this as a growing category. And I think just knowing that we're already hitting top drug lists with a drug that is even not fully available yet, there's some shortage supplies, is making some of our employer clients pause and say, what else can I do here? I want to be able to provide drugs where appropriate, but I also don't want it to be unaffordable, as you mentioned before. So it really is a conundrum, if you will. So we have a couple questions here about the supply chain. And I think we brought that up early in the conversation about, there are so many players within that supply chain. And is there any way to revisit the supply chain, eliminate any of the steps in the supply chain, either reduce handoffs or the number of entities involved? So that is from our Q&A.
Well, that's
so one of the
Ron's
things that
forte.
Yeah, I was going to say that's kind of more my scope, but that's one of the things that we're really looking at. On the generic side, it's really fairly simple. We're purchasing generic medications directly from the manufacturer, and we mark that up a very simple 15% and a $3 dispensing fee and a charge of shipping fee. And just simply the way that we have our business model, we're able to extend generic prices and generic medications to the consumer at a very reasonable cost. Branded medications are incredibly more complicated than that. And there's the whole conversation about gross to net and what the pharmaceutical manufacturers have been trying to do to lower the cost, but the pressure that they receive from some of the bad PBM actors that have, quite frankly, forced them to increase the cost of their medication in order to then provide a rebate. And so what we're really trying to do as an organization is to eliminate that rebate as part of the whole supply chain or structure, and purchase that medication from the manufacturer at that net acquisition cost without the patient assistance programs and copay maximizer programs and all the other rigmarole that people now have to go through in order to find a lower cost, and then sell that medication to the consumer at that lower cost. Because unfortunately, you have 75 million people in this country that have a high deductible health plan, and they're all paying cash for these medications, and they're not benefiting from the rebate. They're paying that higher cost. And so our goal is to eliminate the rebate, contract directly with manufacturers at that net acquisition cost, and pass that to the consumer at the point of sale.
Yeah, I think that is just, it's one of the challenges that is with us all. And I think we are, working towards that model, and it just, the simplification, I think, is really the key.
I also think that with the passing of the Inflation Reduction Act back in August, right? In the coming years, the new model in the Medicare space where CMS is negotiating, the high volume drugs, that's going to be a very new model for us in America. And so that is kind of, in essence, kind of changing the different number of players in the supply chain.
It is. That's a great point as well. And I think something that can, really help, especially in the common chronic condition space. Are there any other sort of things that you would suggest to this group of our audience here that really can help mitigate these costs? We've talked a lot about various things, but is there anything else that we're missing? We talked about having the ability to prescribe food as medicine, along with medication, along with things within the supply chain that we can change, along with regulatory issues. What else are we missing for our group at large?
Yeah, I would just build on something that I think Sharon brought up briefly earlier, but I think is really an important theme to touch on, is making sure that the incentives for the patient are aligned with what's best for the patient and their health. And this notion of having a nuanced way of establishing what are the right copays, or should there be any barriers whatsoever for highly effective, high value, evidence-based treatments. Whether it's food as medicine, which I would argue patients should not be paying a copay for a food as medicine program. Whether it's for as Ron, as you were saying, that metformin shouldn't cost $10. Metformin shouldn't cost anything. You got diabetes and you need metformin, you should not pay a cent for your metformin. We shouldn't create any financial disincentive to accessing metformin. How do we make sure that we have a thoughtful way of creating benefits that engage the patient and sort of being aware of and sensitive to the super high value, super efficacious interventions, and make sure that we eliminate all barriers to those. And with better benefit design, I think we can really drive more behavior towards the highest value interventions.
Any other thoughts here?
No, I'll just pile onto that and agree that better benefit design is needed. And I totally agree that most of these generic medications should be for free, but they need to be priced correctly, right? Right now, if employers are listening to that and hearing me say, wipe out copays for all those generic medications, that's a substantial, it's 20% of their spend. Yeah, if they're priced correctly, and they should absolutely be free, or $1 or $2 for the consumer. There shouldn't be $10 and $20 copayments for some of these medications, and they shouldn't cost the employer group thousands of dollars when it's a $35 drug. And that's something that we see in our business every single day.
I can tell you in the older adult space, we have, our seniors are on about 40% of them 5 or more medications, 20% of them on 10 or more medications. And so although we have a benefit design where 90% of the medications that our seniors are taking are zero, the area that we're focusing on is really that right balance of needing those medications. Because in our healthcare delivery system, we are very good at prescribing, but we're not very good as you age at reassessing. And so we've doubled down our efforts on with our older adults to say, do you need a DPP-4 and a GLP-1, and raising those items up? You've been on a PPI for 5 years. Do you need it? Or you're on 3 medications that all could potentially contribute to falls. And how do we, make sure that the medication fine tuning is happening? Because at the end of the day, a lot of the times when we're doing medication consults, the biggest thank you that folks, at my temple, when I give them their medication consult, when they come back to me, it's not, oh, thank you for saving me money. It is, thank you, I have more time to live my life.
I'm so glad you brought that up.
Just as a pharmacist to pharmacist, we also had a comment in the chat about what about simply reducing the number of scripts written, to your point? Do we really need a pill to fix everything? And I think that's, a lot of what we highlighted here. A couple of other interesting questions from the chat is why isn't anyone discussing the use of devices like CGM for cost savings and robust support for patients? Now, I know we are using them in certain programs and elements, but would like the group to expand on that for a moment.
Well,
I think,
with any of those devices, you sort of have to think about value and not cost. If it's making the patient's life easier, if it's driving better outcomes, if it's leading to fewer hospitalizations, if it's leading to fewer episodes of hypo or hyperglycemia that require attention. I don't know what the right amount of what the right cost is that we say is the amount we should pay to avert those. But I think we should be willing to pay something. We just can't talk about sort of cost in a silo without cost of drugs in a silo. You have to talk about the cost of drugs in the context of someone's health and healthcare, and sort of think about the value of that intervention on all the other outcomes that patient may or may not experience. So CGM is just one example, but it's also true of the GLP-1s. It's also true of the SGLT2s. In diabetes, there's a whole host of these places where there is evidence where there's better technology, and we have to just figure out what it's worth and what we're willing to pay for it. But if people if patients are benefiting, the answer's got to be, how do we get it to patients? As long as there's not a better alternative for them that's out there.
Sharon, were you going to add on?
Didn't know if you were going to comment on that. Okay, great. So we've got 2 minutes left, and I just want to thank the panel again. We'll round out with a couple of other questions from the chat. We have a commentary. Having been in the employer space for 30 plus years, Ron's point to have an independent advocate or auth process is a critically important question. How do we educate, train enough folks to carry that workload?
How do you educate your third party? Or I think you need to work with a third party. Is really what I'm saying. Is there are, rather than working directly with your PBM or your managed care organization that may have an ulterior motive to filling those prescriptions, there are other third party organizations that you can carve out the specialty pharmacy benefit to that will manage it not on a pay to play basis, so to speak, but on a more holistic manner, not necessarily having the incentive to fill the prescription. They don't own the pharmacy. Their only incentive is to help the member have better health and not necessarily fill the prescription.
Thank you so much. And I'm going to wrap up with one last question. Are there any final thoughts that you want to leave the group with today in our last minute here?
I'm grateful for the conversation. I think it's really, really valuable to think about food as an intervention and to think about the value it can produce in the lives. And if Kevin wasn't a good example in the previous discussion, I don't know what is. So this is the right discussion for us all to be having. Thank you.
Likewise. Thank you, Chantell, for moderating. And I think, food, is very powerful in terms of what it can do for every human being. And the more that we can pay attention to that up front, does it minimize diseases as we go through the course of our life? Absolutely.
Thank you all for this really great conversation today. We want to thank the Virta team as well and hope everyone has a great rest of your day. Take care.